Hi, everyone. I want to go ahead and introduce myself. I am excited to be here today, and thanks for joining me for this live Q&A. My name is Sara Arian, and I am a reproductive endocrinology and infertility specialist here at Boston IVF. I'm a double board certified reproductive endocrinologist, both in obstetrics and gynecology, as well as reproductive endocrinology and infertility. I also have a master's degree in clinical research, and I have recently joined the wonderful team at Boston IVF as of now 6 months ago. And I am happy to be here tonight with all of you to go over questions that you may have, fertility or non-fertility, reproductive related, hormonal related. I am going to probably wait a few minutes before I start getting questions. We have already received some of these questions that I'm going to go over with you, and then we'll kind of get started. Generally speaking, while we're waiting for me to receive your questions, one of the most common questions that I get asked by many individuals, many patients, is when to see a reproductive specialist or an REI specialist. And as per the recommendations by the guidelines, by our standard guidelines, typically for a woman who is younger than 35 years of age, if you have been having unprotected intercourse with no contraception, no protection for a total of 12 months or longer, and you have not been able to conceive, then the recommendation would be to see an REI specialist. For women who are 35 years of age and above, the recommendations are that if you have been without any protected intercourse or contraception for 6 months or longer than that, then to see a fertility specialist to start with a comprehensive investigation and evaluation of the entire reproductive system. And for women who are 40 years of age and above, I would probably not wait longer than 3 months of trying on your own to conceive before you start seeking help from a reproductive specialist, from an REI. And then, there are women with the diagnosis of PCOS, polycystic ovarian syndrome, or anytime there's any concern about any hormonal or reproductive issues, women who are concerned about early menopause or premature ovarian insufficiency, and also when you are interested in doing any type of fertility preservation through oocyte or egg cryopreservation or egg freezing or embryo freezing. Women who are not quite ready to start a family of their own and they're interested in preserving their fertility obviously should not hesitate to seek help from a reproductive specialist sooner than later at a younger age to basically seek help. And then for women who already do have history of any menstrual cycle irregularities, irregular periods, any history of severe cramping or heavy painful periods when there's a concern for hormonal problems such as PCOS or endometriosis or issues with chronic pelvic pain or some type of structural abnormalities of the reproductive system, including the uterus, they should also seek help at any time point sooner than later. You don't necessarily have to wait to see your general gynecologist or necessarily have to wait and keep trying before you come and see us. And then other things that I can also think of, if a couple or a woman has experienced early pregnancy losses, so typically 2 or more than 2 early pregnancy losses or spontaneous miscarriages, would give you, by definition, the diagnosis of recurrent pregnancy loss. And at that point, you would want to see a reproductive specialist just to start the process of doing some workup for recurrent pregnancy loss to make sure that from a structural, hormonal standpoint, anatomical standpoint, autoimmune standpoint, there are no issues that need to be addressed prior to seeing prior to attempting another pregnancy. So now that I'm getting more questions look like they're coming. I'm going to start by going over your questions. So the first question that I received is, how long should you wait to start IVF after a miscarriage? I got pregnant on a third round of IUI, which is intrauterine insemination, but only a gestational sac and no baby inside, so had a DNE or a DNC done. Well, first of all, I'm very sorry to hear about what you have been through, and so sorry about this early pregnancy loss with an empty gestational sac. Obviously, you know, there's nothing that we know that you have done to have caused this. And these miscarriages, sadly, are pretty common, more common than what we talk about. We know that 1 in 4 pregnancies, on average, about 25% of these pregnancies, early pregnancies, whether it's through some type of fertility treatment or not, can result, unfortunately, in some type of a miscarriage, early pregnancy loss. And the most common reason for this happening is thought to be some type of chromosomal abnormality at the time of early development of the embryo, at the time of fertilization sometimes. And Mother Nature has this mechanism in place that will prevent from implantation or further growth and development of an embryo that is going to be genetically chromosomally abnormal. So I'm very sorry to hear about that. And then as far as starting the process of IVF, I mean, it can be done pretty soon after a miscarriage. So after a spontaneous miscarriage, we would like to make sure that we monitor and trend your serum pregnancy hormone levels, just to make sure the pregnancy hormone level is back to negative or to 0. And typically from the time that this pregnancy hormone level or HCG level goes back to negative, typically you would expect to start a period within 2 to 3 weeks of that time from the time of a negative pregnancy test. And pretty much at that point, at that time, as long as everything looks good and your ovaries don't have a cyst and everything, you know, looks okay, on a baseline ultrasound, you would be ready to start the process of IVF. So you don't need to necessarily delay things for a very long time. There's another question that I have received. What's your opinion on embryo glue? And so embryo glue is being used by some practices, is being offered or used in some IVF clinics, including Boston IVF, in order to help with increasing the likelihood of implantation of an embryo. And I mean, the data and the studies on embryo glue are controversial. So there are some research studies that have been done that showed some success and improved pregnancy rate as a result of using embryo glue. And there are some that did not show a statistically significant benefit. And in this case, I would say, you know, it's based on the individual. If you have already undergone at least a few rounds of embryo transfers where everything has been, you know, very well controlled for, and your lining has looked good, your endometrial lining has been sufficient and adequate, and there was a transfer of a genetically normal euploid embryo with no success, it may be something that could help. Certainly is not going to cause any harm, so it's maybe worth looking into. But I don't really feel strong about it that you necessarily have to use it every time you undergo an IVF cycle or an embryo transfer cycle. The other question that I get, what kind of exercise can you do after IVF? Do we take rest and not to exert? So this is a great question. Once you start the process of IVF, ovarian stimulation, hormonal stimulation, for about 10 to 12 days, sometimes up to 14 days, women can undergo the process of IVF where you're using these daily shots injections. So this process takes approximately about 2 weeks. And during this time, your ovaries are going to start becoming stimulated as a result of taking the shots, the hormonal injections. So they are going to become larger in size. And this will result in you feeling bloated and a little uncomfortable. And so we strongly recommend that you do not do any high impact exercise activity during that time while you're undergoing the process of stimulation, because you're going to be at increased risk for having an ovary twisted around itself, or ovarian torsion. So we really want to minimize that risk. And so I highly advise that you do not do any type of exercise, again, high impact activity during that time. And then right after the process of IVF with egg retrieval, once the egg retrieval has been done, again, depending on your hormone levels and depending on the number of the eggs that have been retrieved, typically within a few days, we expect you to go back to normal. And at that point, it would be okay to start working out and exercising, except for when you're at increased risk for ovarian hyperstimulation, when you have responded so well to the injections, to the medications, you have high hormone levels, and we definitely want you to stop working out at least for about 10 days up to 14 days, and kind of take it easy until you are completely out of that overstimulated state and it's safe for you to go back to your routine workout and exercise. The other question that I have received, so when it comes time for an embryo transfer, I know with my doctor, I need to decide whether to take hormones, progesterone and other types of hormones or not, whether to use suppository versus injections. How do women look at these different options and decide, especially if it's unknown whether our lining will or will not cause implantation problems? Signing up for a hormone treatment seems statistically wise, but it's so much on my physical body. I think she means a lot to go through, a lot on her body. And you're required to stay on the regimen for a very long period of time. So this is a great question. When preparing a woman's uterus and body for an embryo transfer, there are different types of medication regimens, protocols that we can offer in order to prepare and help thicken up your lining to prepare for an embryo transfer. So there's certainly the more traditional hormonal stimulated type of regimen where we would be using estrogen in the form of oral estrogen peels, or sometimes vaginal estrogen. Sometimes we would use estrogen patches in order to help thicken up the lining. And once the lining is thick enough and is adequate to prepare for an embryo transfer, then we would be adding progesterone, which will be in the form of vaginal progesterone and or intramuscular IM progesterone injections. And that could be a little challenging and hard, difficult for many individuals to have to go through. So there's certainly this type of hormonal preparation in order to prepare your lining for a transfer, versus there are more natural ways and protocols that we can use as long as you don't have any contraindications to using these types of regimens or protocols, or as long as your physician thinks that you would be a good candidate. Sometimes we would not give you any type of hormones, any type of estrogen, and let your kind of body naturally secrete estrogen and monitor your ovulation and monitor the thickness of the lining before we can add the progesterone in order to prepare you for implantation. And sometimes we do a modified natural cycle where we would just have you take an oral fertility pill, that could be letrozole or Clomid, to help boost and strengthen your ovulation and help prepare the lining for an embryo transfer. Typically, when we are preparing you for a transfer, whether it's fresh or frozen, you would need to be on some type of supplemental progesterone, whether it's vaginal or progesterone injections. And so really which protocol to choose, I mean, that all depends. You're right. This could be also a trial and error. We could be trying a protocol and may not be getting adequate response. And then we may have to switch to another type of regimen protocol in order to achieve a good lining. overall, these protocols, none of them are superior. One is not superior compared to the other. So it all depends on if you're ovulating regularly, if you're getting regular menstrual periods, if you had any issues in the past with development of your endometrial lining, endometrial thickness, if you had any procedures done on the uterus previously, if you have issues with intrauterine adhesions, Asherman syndrome, if you are perimenopausal, or if you have a diagnosis of hypothalamic hypogonadotropic hypogonadism, where we would be concerned about you ovulating naturally on your own, or by using an oral pill. So it all depends on the underlying diagnosis and your preferences versus your physician's preferences and their experience with different types of regimens, protocols. Have you seen a successful IVF pregnancy without removing the blocked tube? So it depends, right? So if there's a blocked tube, and if the concern is having what we call hydrosalpinx, which is a chronically inflamed tube, so chronic tubal dilation, which contains basically can contain toxic fluid. So when there is collection of fluid inside of the tube, which then results in hydrosalpinx, the tube needs to be removed prior to performing an embryo transfer, because the fluid inside of the tube can again be toxic to the embryo that's trying to implant inside of the uterus, and can result in failed implantation. And in order to maximize your success with IVF and with implantation of the embryo, that blocked tube that is dilated needs to be removed. However, if it's just a blocked tube without any tubal dilation, it is possible to leave the tube there, or sometimes we would just disconnect the tube from the uterus so that the tube cannot basically communicate with the uterus, and it won't result in failed implantation of an embryo. So it all depends on where the blockage is. Is it proximally, distally? Has it resulted in the tube becoming dilated, hydrosalpinx, or not? Next question. Does the data support calcium activation and increasing blastocyst rate? And this is something, this is more of a novel type of technique that we have been using in our IVF lab. And I would say the data is still, we're still early in having kind of like, we don't have any large randomized controlled trials to say based on these large trials, it has been shown to be beneficial, but there have been some reports and studies showing the benefits of this in women with poor oocyte, egg, or embryo quality. And I would say if you've had issues with failed IVF cycles previously, and if it's something that our lab is capable of offering, I would say that it would be worth looking into and giving it a try, given that it may be helpful and beneficial. Other question, 38 years old, just experienced a no heartbeat at 17 weeks ultrasound. Should we go right into fertility clinic and seek IVF? Thank you so much for doing this tonight. Hard to find time in the day. Yes, of course. I'm so sorry for finding out about this. I'm so sorry for the fact that you had to go through this. So second trimester pregnancy loss at 17 weeks. And I'm very, very sorry about what you have experienced. And again, it's really hard to know. This could likely, if it was a one-time event, could likely be some type of chromosomal genetic abnormality of the actual developing fetus. And if this was a one-time event that randomly happened without you knowing about any type of previous, underlying chromosomal genetic abnormalities on your side or on your partner's side, if applicable, then I probably, you do not necessarily need IVF for this, but I would definitely want, you to kind of definitely talk to your primary OBGYN, possibly a geneticist, to see if this could have been genetic related, if they would suggest you undergoing some genetic testing prior to starting to try again for another pregnancy, if this is something that is chromosomal related, genetic related. But again, if this was a one-time random event, I'm hoping that you can try again and become successful, hopefully without having any issues. So this by itself does not necessarily mean that you will need IVF or you necessarily have to see a fertility specialist. Can you go for walks? Certainly. So I think this person means while you're going through the process of IVF, yes, certainly, absolutely, you can go for walks as long as it's not, again, high impact exercise activity. You can definitely go for a walk, and that's actually something great that you can do. The other question that I have received, and I'm sorry if I'm trying to go through them quickly because I want to make sure I get to all these questions. So how long the day 5 embryo can survive inside the uterus after the transfer. So I'm not quite sure if I'm understanding. So when we do a day 5 fresh embryo transfer, so typically if that embryo is viable, right, meaning if it's a good quality, morphologically a good quality embryo and or genetically normal, and if it has the capacity to later develop into a normal pregnancy, then that embryo will implant and will just continue to grow and develop and survive inside of the uterus, and then later on grow into a more advanced embryo with hundreds of cells, and then begin the process of organogenesis, developing organs early in pregnancy, versus if it's not going to be, if it's an abnormal embryo, or let's say a non-viable embryo, and we do an embryo transfer, then a few things may happen, right? The embryo may implant, but may not further grow or develop into a normal pregnancy that could be detected. It could be that it will be transferred inside of the uterus but won't implant, and that will result in a negative pregnancy test. Or if it does implant and cannot further grow and develop, this can result in an early miscarriage, which can be diagnosed as early as 4 weeks, 5 weeks, 6 weeks. So early pregnancy miscarriage. But if it's a viable normal embryo, it will continue to survive and develop into a normal pregnancy. So I'm hoping that I got this question correct, that I'm understanding what the question exactly is, and my answer is making sense. There's another question. I'm having premenopausal symptoms at age 37, i.e. hot flashes, night sweats, but still having my regular periods. Can I get pregnant and keep the baby? Well, the question is, have you tried? Have you been trying to conceive? Has it been taking you some time? Is it important? Is it time for you to see a reproductive specialist? How long have you been having these symptoms? And have you had any testing done to check your hormones and your ovarian reserve? I would suggest, if you have been experiencing these symptoms for a period of time now, for 6 months or longer, then I would recommend, or if you've been trying to conceive, again, for 6 months or longer, then I would definitely recommend seeing a reproductive specialist, and then we can run some testing. We can check your hormones, including your brain hormones. Most importantly, the follicle stimulating hormone FSH, that can tell us if you're truly in premature menopause or not. And we can also check your ovarian reserve to find out if you are truly in premature menopause. And if you are in premature menopause, then depending on how much is your ovarian reserve and what's your egg quantity, it is still possible to become pregnant. Even natural pregnancy, it is still possible to ovulate on your own and hopefully become pregnant naturally or through IVF. Supplements you can recommend after transfer. This is a great question. So really, after the transfer, the only thing that I would suggest would be to stay on daily prenatal vitamins with folic acid. That would be the only supplement. Now, vitamin D is a great supplement that has a lot of positive implications in a woman's reproductive system and fertility, and also implications in early pregnancy. A lot of us are vitamin D deficient, especially if you are not exposed to sunlight as much. And what I always do for all of my patients is I always check their vitamin D levels while they're undergoing or before we start the process of fertility treatment. And if they are deficient in vitamin D, then I will have them start a high dose prescription vitamin D for at least 8 weeks, followed by over-the-counter supplementation in addition to their daily prenatal vitamins. So vitamin D pretty much and prenatal vitamins are the only supplements that I would recommend after the transfer. There's CoQ10. It's an antioxidant that can help improve egg quality. And I do oftentimes recommend taking that if we have concerns about equality or in women of advanced reproductive age preparing to undergo an IVF cycle. But it's something that has not been well studied in pregnancy, so I would have them stop right after an embryo transfer. There's another question. I'm 33 years old. I have two daughters, 5 and 10 years old, and I'm looking for family planning IVF for carrying a baby boy. Would I have to take the hormonal injections as well? Correct. Yes, you're right. So the only way that we can do sex selection prior to you actually conceiving would be through IVF. There are no other possible ways to obviously do a sex selection. And I know people talk about, trying different timing to have intercourse or different positions, and there are a lot of myths out there, but really truly IVF and performing PGT-A, which is pre-implantation genetic testing of the embryos, will be the only way to determine the sex chromosomes and do sex selection. And that means that, yes, you would need to undergo the process of IVF, which will require you to undergo daily hormonal injections to stimulate your ovaries, and then we'll be harvesting the eggs from the ovaries. You will undergo an egg retrieval, and then in the lab, we will basically create embryos by fertilizing your eggs with sperm. And then once we have the embryos, we can take a few cells for genetic and send for genetic testing and chromosomal testing of these embryos, or PGT-A testing. And then the test result will not only tell us about the sex of the embryos, but also will screen the embryos for any type of chromosomal abnormalities. But it does require hormonal injections in the process of IVF. What should be the minimum progesterone levels on the day of transfer day and in early pregnancy? So this is a great question. There is not really a minimum progesterone level. So please remember that progesterone is a pulsatile hormone, and it's secreted in pulses, right? So depending on what time of the day and on which day we measure serum progesterone levels, the levels may vary. And we don't necessarily only go based off of the serum progesterone level. Yes, we do check your hormone levels. We typically do not check, or at least I in my practice do not check the progesterone level on the day of the transfer. So it's not something that we do routinely. And then in early pregnancy, really, I may check the serum progesterone level, especially if you are on progesterone supplements, in order to modify or adjust the dose. I would say a level of 15 and above would be a good level for early pregnancy. After an embryo transfer, what kind of exercise can you take? So again, this is a great question. Generally, after an embryo transfer, you don't necessarily have to have a lot of restrictions. I would say on the day of the embryo transfer, right after the embryo transfer, I probably would not want you to go do heavy workout and exercise or do running or Peloton, things like that. So I would want you to take that day and probably the next few days until you come for your actual pregnancy test easy. So I would like for you to take those days easy and kind of not do any heavy exercise, workout, things like that. But then after that, after a few days, or once you come in for your early serum pregnancy test, then you're okay to go back to your previous pre-pregnancy exercise level, and that should be totally fine. So obviously, I don't want you to start, working out all of a sudden if you haven't been working out in the past prior to pregnancy. But if you have been having some level of activity exercise, it's totally fine to go back to that level of activity exercise early pregnancy. So let's see what kind of exercise. We talked about that. A fresh embryo transfer failed, and now moving towards remaining embryos that are frozen. What are the chances with frozen embryo transfer, and how sonogram can help in this, and just one embryo? How sonogram can help in this, as there is just one embryo able to freeze. So You may want to repeat your question, but from what I'm understanding, you unfortunately have failed a fresh embryo transfer, and looks like you only have one embryo, frozen embryo left at this time that you're planning on having that transferred. Well, best of luck to you. I'm sorry that the fresh transfer did not work. As long as that embryo is morphologically a good quality embryo and survives the thaw process on the day of your embryo transfer, there's still a good chance. I mean, this also depends on your age and other underlying factors, but I'm hoping that there's still a good chance of that embryo being able to survive the thaw and resulting in a successful pregnancy. So I would say probably about, I mean, as long as it's a morphologically good quality embryo, I would say probably about 50 to 55% likelihood of success. Now, if this has been a genetically tested embryo, I would say the likelihood of success may be as high as 60-65% if we're transferring a genetically tested chromosomally normal embryo. So best of luck to you with your frozen embryo transfer. Do you recommend insemination after fibroids removal? They were not in the uterus. So again, it depends. If you have undergone fibroid removal surgery or myomectomy surgery, as long as all the fibroids that had to be removed in order to improve your chances for successful pregnancy have already been removed, and there's nothing inside of the cavity of the uterus that could result in failed implantation or prevention of implantation of an embryo or early miscarriage. And as long as your uterine cavity is all nice and clean and clear, and as long as your tubes are open, you have open, patent, functional fallopian tubes, then you could still try insemination, obviously, as long as there are normal sperm numbers and parameters, and as long as the other factors are, all good looking and normal. Sonohystogram, ultrasound of the uterus, what are the benefits? So sonohystogram or a saline sonogram, I call it a water ultrasound test, and that's pretty much a vaginal pelvic ultrasound where we would be injecting or infusing some saline, sterile saline inside of the cavity of the uterus. And we use this test mainly to make sure that your cavity looks nice and clean and clear, an optimal place prior to transferring an embryo or prior to starting the process of fertility treatment. So it's mainly to investigate inside of the cavity of the uterus. So when we do a vaginal or pelvic ultrasound, because we cannot really visualize inside of the cavity on a regular ultrasound, we perform a saline sonogram. And when we infuse saline inside of the cavity, we kind of distend the cavity so we are able to visualize inside of the cavity. We can just see, we can look for any lesions, any polyps, anything that can interfere with implantation of an embryo. Does Boston IVF accept embryos from another clinic for transfer only? Also, does the clinic utilize immune protocols? Thank you. Yes, of course, we do accept embryos from other clinics. I have many patients who have done IVF or undergone IVF at other facilities and clinics, and they have transported their embryos to us, to Boston IVF, and have undergone embryo transfers with us. So that's absolutely possible. Does the clinic utilize immune protocols? I would say this really depends on the physician. And I would say when it comes to immune protocols, I mean, this is a little bit of a complex subject, right? Because there are a lot of controversial studies when it comes to using different immune protocols and regimens. And typically, we do this for individuals who have undergone multiple rounds of failed embryo transfer or failed IVF. And so it really depends on your physician, their previous experience with this, and their level of comfort, what they feel comfortable with. So to some extent, I would say most of us will try different things, immune or non-immune related, in order to give you, to maximize your chances of success after an embryo transfer. Is it safe to have a CrossFit type workout the night before a frozen embryo transfer? Well, I don't see a problem. I mean, if this is part of your usual routine workout and you think that is going to be something that mentally can help you throughout the process of transfer, I don't see a problem with that. Obviously, I don't want you to do that when you're undergoing the process of IVF with hormonal stimulation, the injections. But I don't see it being a problem the night before. But again, I probably would not feel comfortable for you to do that right on the day of embryo transfer, like right after your embryo transfer. And the reason is, I really don't want, if the embryo transfer ends up being unsuccessful, I really don't want you to kind of blame yourself or think that, it is likely because of that very high impact exercise activity you did that could have caused something that resulted in failed implantation. So the night before with frozen embryo transfer, as long as you are up for it, I would think that is okay. So if my receptive hours from ERA testing is 130 plus or minus 3 hours, then how long I might be receptive. So they will the ERA test will guide us, will tell us, like, based on their receptivity, if you're pre or post receptive, then it will, the test itself will tell us how many hours of additional progesterone you would have to stay on, and when to plan for your embryo transfer. And I would say that, the window of receptivity, depending on your age and underlying conditions, can be pretty wide, but that's why we use the ERA testing, meaning based on the test, your team, your physician's team should communicate with you to tell you how many hours of progesterone do you have to be on before we plan on doing your frozen embryo transfer. I'm 37 and my REI suggested IUI. As of now, I've also decided to do the parenting work on my own as a single parent. I'm worried about the possibility of having twins at this age. As a single parent, I would rather just have one baby. What do you do to reduce the possibility of having twins or multiples? It's a great question. Congratulations on wanting to start this process. So I would tell you that with the process of IUI, typically we would have you take an oral fertility pill. So depending if this is going to be a natural cycle for you or a medicated cycle. If it's a natural cycle, we will monitor your natural ovulation, and typically, we will monitor to find out if you're at a time point where you have developed a mature follicle, mature egg, and you would be ovulating soon. And if it's a medicated cycle, then we would have you take an oral fertility pill to help induce ovulation or strengthen and boost your ovulation. And so if you are doing this naturally on your own without taking any hormonal pills or any oral fertility pills, then we would just, again, monitor your natural cycle and natural ovulation process. And even if, we would typically expect you, unless you have some type of ovulation disorders, we would expect you to be ovulating 1 egg every month. And even if you were to ovulate 2 eggs that month at age 37, the chances that both of those eggs are going to be genetically normal and fertilized by sperm are not going to be as high. So I'm not too worried about that risk. Now, remember, there's always a risk, right? Less than 5% probably, that one egg may split into 2, or one embryo later on may split into 2, which can result in a twin pregnancy. But, that risk is basically the same as similar to general population. So not necessarily increased by undergoing the process of IUI if it's a natural cycle IUI. Now, if you're taking oral fertility medications to help induce ovulation and help boost your ovulation, then typically I would say likelihood for having twins without taking any type of oral fertility pills is about 3%. So 3 in 100 people, when they're trying to conceive, they can end up with a twin pregnancy. When you're taking an oral fertility pill such as Clomid or Letrozole, this likelihood will be increased to about 6 to 9%, still less than 10%, so still not as high. And then typically the likelihood for having higher order multiples is not going to be as high with IUI. If it's a monitor cycle, your physician will be monitoring your cycle. And worst case, if you end up developing four follicles, four mature eggs, which is highly unlikely at age 37, then there's a likelihood that your physician may have to cancel your IUI cycle for that month. But highly unlikely. I would not be too worried about that, honestly. Hi, I have a transfer on Monday and I have PCOS. Any recommendations? Any special food to take those days? Thank you. So you have an embryo transfer scheduled for Monday. Congratulations. And I'm very excited for you. Best of luck to you. Keeping my fingers crossed. Really, I mean, nothing specific that you would have to do other than following the instructions that have been sent by your nursing team and physicians team with the progesterone, taking progesterone, whether it's progesterone injections or suppository vaginal progesterone. Just a diet that in general I highly recommend for anyone who's undergoing fertility treatment or trying to be healthy, especially in women with PCOS, would be a Mediterranean diet. So if you look up Mediterranean diet, it's a diet that really focuses on eating fresh fruits and vegetables and plant-based products and minimizing the amount of red meat and processed food and processed carbohydrates and eating more complex carbs and healthy sources of fat. And that would be the diet that I typically recommend for all of my patients who are undergoing fertility treatment. And obviously staying on your daily prenatal vitamins and making sure your vitamin D level is adequate and, avoiding smoking and alcohol, things like that, right before the transfer and obviously after the transfer. So best of luck to you. When would you use ICSI, which stands for intracytoplasmic sperm injection? Is that standard or does it depend on the sample provided prior or based on the prior sperm analysis? This is a great question. So ICSI stands for intracytoplasmic sperm injection. It's a fancy name, terminology that we use basically to describe a procedure that is done through IVF where we would be taking eggs from the female partner and sperm from the male partner, and we would directly inject each of the eggs with the sperm in order to fertilize those eggs. And so the indications for ICSI are typically when there's some type of underlying issues going on with the sperm. So one important indication would be when there's male factor infertility or any issues with the sperm parameters. Whether it's low sperm counts or poor motility or movement of the sperm or abnormal sperm morphology or shape of the sperm. And we do use ICSI in this setting in order to help improve or maximize the likelihood for fertilization. Otherwise, in the absence of any male factor, as long as all the sperm parameters are completely normal, you don't necessarily have to undergo ICSI. In that case, we would recommend a conventional or traditional type of insemination IVF, where we would put the eggs directly in contact with the sperm in the IVF lab in culture media and let sperm basically fertilize the eggs. Is embryo quality really that important? I have a bunch of 3BB or 3BC. Well, I mean, embryo quality is basically a grading system, right? A grading system that our embryologist, our IVF lab, will give to each of these embryos based on how the embryo has been growing and developing, right? So the first number correlates with the degree of the expansion of the embryo, or in the case of a blastocyst, the degree of expansion of the blastocyst. The first letter correlates with the quality of the inner cell mass, what becomes the future embryo, the future fetus. And then the second letter correlates with the quality of the outer part, the trophectoderm, which becomes future placenta. And, this grading system can be objective, right? Based on the grading system that the embryologist is going to use and, based on what they observe. And, it's not 100% accurate thing, I would say, that can determine the success with implantation, meaning the slightly lower quality embryos, if we have, a 3BB versus a 3BC or, a 4AA, I mean, even slightly lower morphologic morphologically lower quality embryos are still capable of implanting and developing into a normal pregnancy. So I would say probably the genetics of the embryo and the chromosomal components are more important in determining implantation capability of the embryo, but quality can also be important. But really, there are also poor quality or slightly lower quality embryos that still do have the potential of developing into a normal pregnancy. So I wouldn't really worry about focus too much on the quality or morphological grading of the embryo in this setting. Chance of success of transferring 2 embryos, 4BB and 4BA, 32 years old with unexplained infertility. Well, I would say these are great quality embryos. I mean, 4BB is a great quality, 4BA is still a decent quality embryo, and you're young. So I would actually be a little worried about transferring 2 embryos because I would be worried that I'm increasing your risk for having twin pregnancy or higher order multiple pregnancies. So I would think that there is a high likelihood that you can hopefully become successfully pregnant even after transferring 1 embryo. And typically, elective single embryo transfer ESET is what I would highly recommend in women who are younger. Now, obviously, I don't know your whole story and how many rounds of IVF have you done or how many failed transfers you have had, if you've had any, and that may change the decision as to how many embryos to put back. But my inclination would be to transfer only 1 embryo, because I think you would still have a high likelihood of success even after transferring 1 embryo. So best of luck to you. Have you seen a successful pregnancy with bilateral distal hydrosalpinx but open tubes and having IUI? My doctor does not think removal of this is necessary yet and wants to be conservative because of my age of 28. So I'm trying to read this again. So bilateral distal hydrosalpinx but open tubes and having IUI. I mean, I would feel a little worried about that. I mean, if you do have bilateral tubal disease, especially if, bilateral hydrosalpinx, even if it's distal, I would be tempted to remove the tubes, honestly. And with bilateral tubal disease, I'm also concerned about your increased likelihood for having an ectopic pregnancy or a tubal pregnancy. So that would make me feel a little worried, even if the tubes are normal, unless your physician doesn't really feel that the hydrosalpinx, I mean, he doesn't really truly believe that you truly do have hydrosalpinx and true dilation of both of the fallopian tubes. But I obviously cannot give any personal medical advice because I really don't know your actual underlying diagnosis, but that would make me a little worried about wanting you to try IUI without addressing those fallopian tubes. And I think in the setting of having bilateral tubal disease, IVF may be a better option. And I would also worry about, with having the tubes there, if they're chronically inflamed and damaged, I would worry about the risk for having an ectopic pregnancy. Do you recommend Receptiva tests? So let's talk briefly about Receptiva tests. So Receptiva is a new add-on fertility test that we are starting to learn kind of more about, and the research is still ongoing. With Receptiva, it's an endometrial biopsy type of test, which takes a sample tissue of the lining of the uterus and then evaluates that endometrial sample for inflammatory markers, which could be markers of endometriosis or chronic inflammation. So in women who have had multiple prior failed embryo transfers, especially if we are concerned or we are suspicious about the diagnosis of endometriosis, then sometimes we may use, or I may offer Receptiva to investigate those inflammatory markers. And then if the Receptiva comes back positive, suggestive of some type of chronic inflammatory process going on that can result in failed implantation, then I would suggest suppressing and downregulation by using Lupron injections, sometimes combining that with the oral pill, letrozole, for about 2 to 3 months prior to moving on with another embryo transfer. So there is a role for it, I would say, but not for everyone. What could be the cause of multiple back-to-back ectopic pregnancies with no tubal blockage? I mean, there must be some type of underlying, tubal scarring or tubal damage or issues with the fallopian tubes, right? So the tubes may not necessarily be functionally or anatomically blocked based on the HSG testing or the tubal testing, but functionally there's something going on with these tubes, some underlying tubal disease that has resulted in multiple ectopic pregnancies. So there's definitely something going on, whether it's an old infection that's, is there without you not even knowing about, or some type of tubal scarring, some type of tubal damage as a result of endometriosis or other underlying structural issues, even if the tubes are not blocked. How long does the PGT-A test the day 5 embryo takes to implant after transfer? So typically we would transfer an embryo, a PGT-A tested embryo, euploid embryo, and then the process of implantation can take up to about a few days at least some time, a day or two, and then we typically can check pregnancy hormone levels as early as 10 to 12 days after an embryo transfer. A fresh transfer of an embryo failed, and now we're proceeding towards one embryo that the physician is able to freeze. What are the chances to get pregnant? So I think I already answered this question, that there was a failed fresh transfer and then preparing for a frozen transfer. So it all depends on the quality of the embryo that is frozen, and depends on your age, underlying diagnosis, and if the embryo has been tested or not. And I'm gonna now try to, I know we're about to run out of time soon, so I've received a lot of questions in advance. I'm gonna try to go over some of these. I'm seeking fertility support because we're a queer couple. I'm 30 and planning to do IUI. All my tests are clear except subclinical hypothyroidism with a TSH level of 3.8. What are your thoughts about treating the thyroid versus just trying, given we will be paying for sperm for each attempt? So with a thyroid hormone TSH level of 3.8, I would highly consider treating with levothyroxine. I also do check thyroid antibody levels for all of my patients. And in this case, so if you have positive anti-TPO antibody, there's definitely a strong indication for you to receive treatment. But even in this, without having a positive thyroid antibody or anti-TPO, elevated anti-TPO level, I would still treat for a TSH of 3.8. My cutoff would be 3.5 and above without presence of any thyroid antibodies, and then TSH of 2.5 and above in the presence of thyroid antibodies to treat you with a very small dose of levothyroxine in order to optimize your chances for success. Why did my doctor give a prescription for metformin? So this could have been due to many reasons. It could be because of the diagnosis of PCOS, but that does not mean that all women with PCOS should be receiving metformin. Most likely this was due to your blood sugars being elevated. So it could have been due to having the diagnosis of prediabetes, or sometimes, diabetes, true diabetes, or sometimes, issues with metabolic issues with insulin resistance we would want to prescribe metformin in these settings to help with lowering your blood sugar levels and improving your metabolic parameters. I am 43 years old, have never been pregnant, and I want to know if I have a chance to be pregnant, and then I have a large fibroma, which I think you made a uterine fibroid. Well, I would definitely suggest that you see a fertility specialist, because We could perform testing. We could also perform a vaginal or pelvic ultrasound, depending on how large this fibroid is, and also depending on where the exact location of the fibroid is. If it's causing you to have symptoms, then it's something that may have to be addressed at your age of 43, as opposed to you coming back a few years later and wanting to have it removed. And we can also do some order blood work testing to kind of talk to you about your reproductive chances and reproductive potential and options. I have PCOS. I've been tracking my ovulation. It seems to be that I'm constantly ovulating with a small peak every 4 to 5 days. Is this normal for someone with PCOS? I only get my period 2 to 3 times per year. Yes, you're absolutely right. PCOS women, especially if you're not having regular monthly period cycles, that means you're not ovulating regularly. And there's no point in tracking your ovulation using these home ovulation kits, because in most women with PCOS, these tests are going to be false positive, because in PCOS, you have you have issues. You have some problems with the pulsatility of one of the brain hormones known as LH, and this is the hormone that is going to be measured for this ovulation test, or the home ovulation tracking test. And your LH levels are constantly high, which can then result in a false positive ovulation test at home. And just the fact that you're telling me that you are getting your periods only 2 to 3 times per year, that's telling me that you're not ovulating. Number one indication for normal ovulation in a woman is for a woman to have monthly regular periods. And if you're not having that, that means you're not ovulating. So I would stop checking. What do you think of an antagonist protocol plus letrozole or Clomid? Will letrozole or Clomid provide additional benefit for increasing quality or quantity of the eggs retrieved? Sometimes I use this protocol. I have definitely used it in the past. Sometimes I do use it in women with diminished ovarian reserve, decreased ovarian reserve, or women who are older. Sometimes I use this Clomid flare protocol or letrozole to kind of give you an initial flare, and I found it to at times be helpful and beneficial in increasing the quantity of the eggs retrieved. Not necessarily the quality, I would say, because remember, the most important predictor for a woman's egg quality and embryo quality will be age. So not necessarily going to impact the quality of the harvested eggs, but can have positive impacts on the quantity. And I've certainly used it in the past and do use it sometimes in the setting of diminished, decreased ovarian reserve, or concerns with the low egg numbers, or in women who have had prior failed IVF cycles. I am 39 years old. I have one child with the help of Clomid and IUI, which we used after 6 months of trying by ourselves with no reason for infertility. Should I see Clomid right away for trying to get pregnant again, or due to my age, or do I still try for 6 months naturally? Well, given this history before and the fact that you have required an IUI and also used Clomid before, and given your age of 39, I'm okay with you trying on your own, probably for about 2 to 3 months. I'll be honest, I would not want you to wait for longer than 3 months. So I would seek help, and I would want to get started with a basic fertility workup after, I would say, 3 months. So see us sooner, I would say, than having to wait for 6 months before you come back and see us. For dealing with everyday pain, headaches, and etc. I understand Tylenol is one of the few safe drugs to use after undergoing frozen embryo transfer. Do I need to be mindful of dosage differences within the daily limit of Tylenol? Extra strength 500 milligrams okay, or should I consider a lower dose? No, I think the regular dose is totally fine. Tylenol is one of the safest options in pregnancy, so we would want you to avoid taking Motrin or Advil early pregnancy, and Tylenol is perfectly fine for you to take even the extra strength for usual pain and aches. And then how long will the whole process take? I will travel and want to plan accordingly, I think is what you're asking. So I think you're asking about the process of IVF. And so the process of IVF, the hormonal stimulation part can take up to about 2 weeks of hormonal stimulation. On average, roughly about 10 to 12 days of daily hormonal shots, injections. Sometimes it can be as long as 14 days or 2 weeks. And I would not travel during that time because you need to know that IVF is pretty much like having a part-time job. You will have to have, time dedicated in order to take the shots, injections. You would have to come in every few days for ultrasound monitoring, blood work, and then you would have to be ready and available, obviously, whenever your ovaries are ready for the process, for the procedure of egg retrieval. So we're really at the mercy of the ovaries, and the timing will depend on when the ovaries are going to be ready. So I would probably either travel first and then come back and start the process of IVF, or I would not be traveling during that time. What can be the reason if 16 eggs were retrieved in fresh transfer and afterwards just one embryo was able to be frozen? So probably there in general, there's a lot of loss in the process of IVF. And this is not just IVF, this is part of natural, normal human reproduction, right? So not all of the eggs that are going to be harvested are going to be mature and good quality. Not all of the good quality eggs are going to be able to be fertilized with sperm. So on average, fertilization rate is about 60 to 65%. Not all of the fertilized eggs can make it to a blastocyst, which is a more advanced stage embryo. And of those blastocysts, if we send them for genetic testing, not all of them can come back as genetically normal. So it's unfortunate that you lost so much from 16 eggs only to one embryo. This could have been, where was the loss? Was it a lower fertilization rate? Was it a low day 3 embryo, cleavage stage embryo development? Was it a poor blastylation or blastocyst development formation? Can be egg dependent, or it could be sperm related, or it could be a combination of both. Most likely a combination of both poor quality egg and sperm. I have embryos frozen, want to use one for a sibling for my son. Is it too late to do PGT? So to have a girl, well, it is possible if you have embryos frozen. So one option is to thaw your embryos, take a few cells, send them for genetic testing, biopsy, and then refreeze the embryos while we're waiting for the results, and then plan on doing an embryo transfer. It's certainly possible. It's not my favorite thing to do, just because I feel like you were at that point putting the embryos through a lot of stress by thawing them, taking a few cells, sending it for biopsy, then refreezing them, and then rethawing them. So there may be a potential risk of harm to the embryos at that point. It's better to do PGT-A upfront on fresh embryos if possible, but if this is something that you absolutely want to do, I think it's certainly doable. And then I'm just getting a lot of questions. I know Emily just sent a message. Thank you for joining us tonight. I'll be happy to have another session here to go over. I've just received a lot of questions, and I apologize if I have not been able. Just looking at the list of the questions there's a huge list here, and they keep on going. So I really apologize. I was not able to get to all of your questions. I'll try to answer one more, and then hopefully we'll have some future events and seminars and webinars where I would be able to help answer more questions. But I hope this session was helpful. I just have one more question here. Let's see. Is omnitrope or growth hormone, human growth hormone, useful to help improve egg or embryo quality, especially in the case of endometriosis? Well, again, it's one of those controversial topics in our field. So there have been some studies done previously that have shown some benefit in using growth hormone to help improve egg and embryo quality, and versus there are some studies that have not really shown a lot of benefit to that. And I want to say there has been at least one, if not more, large study, like a meta-analysis that put all of these studies together, and they concluded that it really is not going to be as beneficial. And plus, we know it's expensive. It does come with side effects. So, I would say it's not something that I would typically maybe there was a period of time based on some studies that I was using growth hormone in order to help improve egg quality, embryo quality, especially after multiple failed rounds of IVF. But I kind of have stopped doing that in my practice based on these larger meta-analyses and studies that have come out. It's one of those things that I would say, again, depends on your physician's experience. But the data overall is not as impressive, I would say. All right, with this, I am going to end our session tonight. Thank you so much again for joining me. And if you are interested in seeing me, making an appointment, I would be more than happy to see you. I see patients at our Quincy office, but I'm also over at the Waltham office for procedures, for surgeries, hysteroscopies. I do perform surgeries as part of my practice, myomectomies, and I will be happy to see you. So I hope this was helpful, and I look forward to seeing you, hearing from you. Hopefully we can have more Q&A sessions in the near future. Thank you. Have a great night.